In a small clinic in Quezon City, Manila, a young nurse named Maria Reyes carefully cleaned a wound on an elderly patient's leg. She worked with gentle precision, explaining each step in Tagalog, making sure the patient felt safe and understood. Maria had graduated top of her nursing class, passed her board exams with flying colors, and spent 3 years working in one of Manila's busiest public hospitals. She had delivered babies during brownouts, tried gunshot victims in overcrowded emergency rooms, and held the hands of dying patients when no family could afford to stay. But Maria wanted more, not for herself, but for her family. Her father had suffered a stroke and could no longer work. Her younger siblings needed to finish school. So, when the opportunity came to apply for nursing positions in the United Kingdom, Maria didn't hesitate. She spent months preparing her documents, translating transcripts, gathering recommendation letters, and saving every peso for application fees. Finally, the date came when she submitted her portfolio to several NHS hospitals across England. She waited anxiously for weeks, checking her email every hour, praying for just one acceptance. When the replies finally arrived, her heart sank. Rejection after rejection. The reasons were polite but clear. Your degree is from a non-UK institution. Your training does not meet our standards. We require nurses educated within recognized Western frameworks. One hospital administrator had been blunt in a follow-up email. We appreciate your interest, but nursing is a profession that requires rigorous, standardized education. Unfortunately, degrees from developing countries like the Philippines do not carry the same weight here. Maria read that line over and over. Developing countries does not carry the same weight. As if the patients she had saved, the emergencies she had managed, the skills she had honed meant nothing because they happened in Manila instead of Manchester. She cried that night, not from self-pity, but from frustration. She knew she was skilled. She knew she could help. But the system had already decided she wasn't good enough before she ever set foot in England. Still, Maria refused to give up. If UK hospitals wouldn't hire her as a nurse, she would find another way. She applied for a healthcare assistant position, a role far below her qualifications, at a struggling hospital in South London. The pay was a fraction of what nurses earned. The work was grueling, and she would be doing tasks she had supervised others to do back home. But it was a door, and Maria had learned long ago that Filipinos don't need the front door. They find windows, side doors, cracks in the wall. She was hired. Her first day at SD. Catherine's hospital was overwhelming. The building was old, understaffed, and drowning in bureaucracy. Nurses rushed from patient to patient, barely making eye contact. Doctors barked orders without listening. Patients lay in beds for hours without anyone checking on them. The staff was exhausted, burnt out, and defensive. Maria watched it all quietly, observing not just the medical work, but the gaps, the missing pieces, the things that weren't being said. As a healthcare assistant, Maria's job was simple. Change bed sheets, help patients to the bathroom, deliver meals. Tasks that required no medical degree. But Maria couldn't help herself. When she saw a patient struggling to breathe, she didn't just call for help. She elevated the bed, adjusted the oxygen flow, and stayed until the patient stabilized. When an elderly man became confused and agitated, she didn't restrain him. She spoke to him gently, learned his name, asked about his family, and within minutes he was calm. The other staff began to notice. Who is this healthcare assistant who moves like a nurse? Why does she know how to read monitors, spot early signs of sepsis, de-escalate psychiatric patients? One night, During a particularly chaotic shift, a young doctor named Dr. Sarah Collins was overwhelmed. 3 patients were crushing at once, alarms were screaming, and the nurses were tied up with emergencies in other wards. Drive. Collins stood frozen, unsure which patient to prioritize. Maria was nearby, restocking supplies. She saw the panic in the doctor's eyes. "Doctor," Maria said calmly, "Bedford has elevated troponin and St. changes. That's the urgent cardiac case. Bed 7 is post-op hypotension, likely fluid responsive. Start there. Bed 9 can wait 2 more minutes. Doctor." Collins stared at her. "How do you know that?" "You're a healthcare assistant." Maria didn't answer. She just moved toward bed 4, already pulling the crash cart. Doctor. Collins followed, and together they stabilized all 3 patients. Afterward, Doctor. Collins cornered Maria in the hallway. "Who are you?" Maria hesitated, then spoke quietly. "I was a nurse in the Philippines for 3 years, but my degree isn't recognized here." Dr. Collins looked at her for a long moment, then shook her head in disbelief. "You just saved 3 lives and you're not even allowed to be called a nurse here." Maria shrugged. "That is the system. Drive." Collins didn't forget that night. She began watching Maria more closely. She saw how Maria could predict complications before monitors beeped. How she could calm terrified patients with just her presence. How she moved through chaos with the quiet confidence of someone who had seen far worse and survived it. One afternoon, Dr. Collins invited Maria to coffee. "I've been a doctor for 5 years," she said. "I trained at Oxford. I did my residency at one of the best hospitals in London. But I've learned more from watching you in 3 months than I learned in half my training. Why?" Maria thought carefully before answering. "In the Philippines, we don't have the luxury of specialization. A nurse is a counselor, a pharmacist, a social worker, a translator, a family mediator, all at once. We don't just treat the disease. We treat the whole person, their family, their fears. We work with nothing and make miracles happen. That's not because we're special. It's because we have to." Drive. Collins leaned back, eyes wide. "That's exactly what's missing here. We've become so focused on protocols, efficiency, legal liability, that we forgot how to actually care. How to see the patient as a human, not just a case number." She paused, then asked, "What if you could train our staff? Not as a healthcare assistant, as a clinical educator. Teach them what you know?" Maria laughed softly. "Doctor, they don't even recognize my nursing license. How would I teach anyone, Doctor?" Collins smiled. "Leave that to me." Over the next weeks, Dr. Collins went to war with the hospital administration. She presented data showing that patient outcomes improved on shifts when Maria was working. She showed how Maria had prevented medication errors, caught early sepsis, de-escalated violent incidents, all while officially being paid to change bedsheets. She argued that the hospital was sitting on a goldmine of expertise and ignoring it because of bureaucratic snobbery. The administration resisted. "She's not qualified under UK standards. We can set a precedent. What will the regulatory body say?" But Drive. Collins didn't back down. She brought in other doctors who had worked with Maria. She rallied nurses who had seen her in action. She even brought in patients who credited Maria with saving their lives. Slowly, reluctantly, the administration began to crack. Finally, a compromise was reached. Maria would be hired as a patient care quality consultant, a newly created role. She wouldn't officially practice as a nurse, but she would train staff in patient-centered care, crisis de-escalation, and holistic assessment. It was a bureaucratic workaround, but it was enough. Maria's first training session was in a small conference room with 12 skeptical nurses and doctors. They sat with arms crossed, barely hiding their resentment. "This is the healthcare assistant who's supposed to teach us," whispered one nurse. "What's next?" The janitor teaching surgery. Maria stood at the front of the room, feeling their judgment. She took a deep breath and began. "I know you don't think I belong here. I know my degree means nothing to you, but I'm not here to prove myself. I'm here because your patients are suffering. Your staff is burning out, and I've seen this before. In Manila, we had one nurse for every 50 patients. We had no supplies, no backup, no funding. But we had something you've lost. We had heart. We had Bayan. That means community care. It means no one is left behind." She walked them through real scenarios from her time in Manila. A mother in labor during a typhoon with no electricity. A child with dengue hemorrhagic fever and no available ICU bed. An elderly diabetic with no money for insulin. In each case, Maria explained not just the medical interventions, but the emotional intelligence, the resourcefulness, the human connection that made survival possible. By the end of the session, the room was silent. One nurse, an older woman named Margaret, who had been the most skeptical, raised her hand. "I've been a nurse for 30 years, she said, voice shaking, "and I've forgotten why I became one. You just reminded me." Word spread quickly. Maria's training sessions became the most requested in the hospital. Doctors who once ignored her now asked for her input during rounds. Nurses started implementing her patient-centered techniques. Slowly, the culture at ST. Catherine's began to shift. Patient complaints dropped. Staff satisfaction improved. Even infection rates decreased because Maria had taught them simple hygiene practices common in low-resource settings that Western hospitals had overcomplicated. Then, 6 months after Maria started her consulting role, a crisis hit. A new strain of respiratory virus swept through London, overwhelming hospitals. St. Catherine's was inundated with patients, running out of beds, ventilators, and staff. Doctors and nurses were collapsing from exhaustion. Protocols were failing because they were designed for normal conditions, not mass casualty disasters. The hospital CEO called an emergency meeting. "We need solutions now. We shut down this swing and transfer patients elsewhere. But there's nowhere to transfer them. Every hospital in London is full. Doctor." Collins stood up. "I know someone who can help. She's managed worse with less." They brought Maria into the command center. The CEO looked at her with barely concealed doubt. "You're the healthcare assistant turned consultant." Maria met his eyes. "I'm the nurse from Manila who kept an emergency room running during typhoons, earthquakes, and blackouts. If you want to survive this, stop talking and start listening." The room fell silent. The CEO nodded slowly. "What do you need?" Maria moved to the whiteboard and began sketching a rapid response system based on what she had learned in the Philippines. Triage zones, rotation schedules that prevented burnout. Community health volunteer systems where recovered patients helped care for others, low-tech. Monitoring solutions when machines were scarce. Psychological first aid protocols to keep staff sane. Every idea was simple, scalable, and proven under fire. Within 48 hours, St. Catherine's implemented Maria's system. It worked, while other hospitals crumbled. St. Catherine's fell. Patients received care. Staff stayed functional. The media noticed. Headlines appeared. How one London hospital survived the crisis inside ST. Catherine's miracle response system. When journalists asked the CEO what made the difference, he paused, then said something that shocked the nation. We hired a Filipino nurse whose degree we didn't recognize. She became the most valuable person in this hospital. We were arrogant, we were wrong, and she saved us anyway. The story went viral. Filipino communities across the UK celebrated. The Royal College of Nursing launched an urgent review of foreign credential recognition. Other hospitals started hiring Filipino consultants. The narrative began to shift. Maybe, people whispered, we've been ignoring a generation of brilliance because we were too proud to look beyond our own borders. Maria stood in the hospital lobby one evening, watching the sunset through the tall windows. Collins approached, holding two cups of tea. You did it, she said. You changed everything. Maria shook her head. I just did what I was trained to do. What every Filipino nurse is trained to do. Survive, adapt, care. Dr. Collins smiled. You know the board wants to make you Director of Clinical Excellence, right? Full salary, full authority. You'll be leading the people who once rejected you. Maria sipped her tea, thinking of her father back home, of her siblings in school, of every Filipino nurse working in a foreign country being told they're not good enough. She thought of the elderly patient in Quezon City whose wound she had cleaned so carefully years ago. And she realized something. She had never stopped being that nurse. The one who cared. The one who stayed. The one who refused to let anyone be invisible. She looked at Dr. Collins and said, I'll take the job. But only if we create a scholarship program for nurses from developing countries. If we train them not to forget where they came from, but to use it. Because the future of healthcare isn't in London or New York. It's in Manila, Lagos, Delhi, and every place the world has looked down on. That's where the real experts are. That's where survival is an underdog doctor. Collins nodded, tears in her eyes. Let's build it. So the next time someone tells you your degree doesn't matter, that your experience doesn't count because it happened in the wrong country, remember Maria Reyes. Remember that systems are built by people, and people can be wrong. Your worth isn't defined by a piece of paper or a passport. It's defined by the lives you've touched, the knowledge you carry, and the courage to keep going even when every door is slammed in your face.